History: 44-year-old male painter complains of weakness of all the four limbs since 10 months following a road traffic accident.
Okay. So what do you think it is?
Sir, the patient has come with quadriplegia. So this can be from the history. It can be a spinal cord lesion or which may be caused due to the trauma, following the trauma, or then other causes of quadriplegia. It can be either a motor neuron disease. It can be Guillain-Barré syndrome. Then it can be high cervical cord compression. Uh, then uh, then cervical spondylosis. Then bilateral brain stimulation. Then um, acute. No, it can be a uh, myopathy or a polymyositis.
So what is the difference between quadriplegia and diplegia?
Quadriplegia is affecting all the four limbs, uh, and diplegia means either of the two limbs are affected.
For example,
Uh, uh,
for example,
Paraplegia,
para-
stroke causing
stroke causing hemiplegia is hemiplegia.
hemiplegia,
Lower limbs are paralyzed called paraplegia.
paraplegia,
All the four limbs are called as quadriplegia.
quadriplegia,
One limb alone is called as monoplegia.
monoplegia.
And what's diplegia?
Both the upper limbs are affected.
Fine, very good. Symmetrical parts of the body are paralyzed.
Okay. Okay.
Maybe
Sir.
face, maybe the upper limbs, maybe the lower limbs.
Okay. Sir.
So this patient has got post-traumatic paraplegia. So good thinking.
Okay, sir.
So what all details you want in this case?
History. We should ask whether it was the progressive. It is a progressive condition. So we can ask whether patient is having any sensory loss.
Yes, he has got sensory loss.
Then whether any cranial nerve involvement. Then
Symptoms of cranial nerves are absent.
then bladder and bowel involvement.
He is incontinent.
Then we can we can assess for the muscle power.
That's an
Grade.
examination.
Okay, sir. Then
So you asked about sensory, you asked about motor, you asked about autonomic. So you asked about your attempt is to localize the lesion.
Yes, sir.
Okay. Any other details you want?
Whether the patient is having any altered speech, any aphasia.
No. Above the upper limbs, he is perfectly fine.
Okay. Then history of pain.
Would you like to ask him why he has come to the hospital?
Yes, sir.
Yes. We must know. He has come for very bad sore and fever. That's his problem now.
Okay, sir.
Anything else you want to ask? He was catheterized since then. Now he has got spontaneous flexion of lower limbs. What do you make out of that?
4 months. It is an ascending paralysis.
When you get spontaneous sudden flexion of lower limbs, whenever you touch any part of the lower limb, what do you call that situation?
Spasm, flexor spasm.
Flexor spasm. In the case of paraplegia, what does flexor spasms indicate to you?
Paraplegia with flexor spasm.
It indicates that the spinal cord transection is severe and affects all the descending extrapyramidal fibers.
Okay.
What is mass reflex?
Um, Mass reflex. Urinary symptoms and defecation. Bowel and bladder is also affected.
And patient also has got sweating, profuse sweating,
Sweat.
along with the flexospasm. What are
Okay.
the other involuntary movements you ask in a case of paraplegia or quadriplegia?
Um, uh, Involuntary fasciculations.
What is
Uh,
fasciculation?
they are involuntary rhythmic movements which are seen in a muscle at um, firing rhythmic movements of a motor unit
So, what is the meaning of rhythmic?
um, um, occurring one after the other in a regular pattern.
So, that does not take place with the fasciculation.
Okay, sir.
Fasciculation comes at irregular intervals. It is not rhythmic at all.
Okay,
When
sir.
you use the word rhythmic, it should be regular intervals.
Okay, sir.
So it's not rhythmic. It is a involuntary contraction of
Motor unit.
a
Entire
fascicle.
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 Okay, sir.
What is fibrillation?
Um, fibrillation is a
Involuntary
single involuntary contraction of a single muscle.
fiber is called as fibrillation.
Uh,
So in a case of paraplegia or quadriplegia, how does fasciculation help you?
uh, Presence element. It is a indicator of an element lesion, lower motor neuron
It
lesion.
indicates lower motor neuron, the correct answer. It indicates some irritation is going on.
Yes.
Can you give some example where patient is paralyzed and you got fasciculation?
Um, Paralyzed. Motor neuron
Motor neuron is a classical example. In the case of paraplegia or quadriplegia, if you get localized fasciculation, that localizes the site of the lesion. If you have
okay.
fasciculation of deltoid, that means there is some irritation going on at the level of C5.
Okay, sir.
That's what it means.
Okay.
Past history, do you want to know anything more?
Um, uh, whether, whether the patient have had any what was done for the RTA, the road traffic accident, whether it was treatment of RTA.
Was
Uh,
given and he didn't respond. He didn't do well. Hmm.
okay. Then
Family
uh,
history, would like to ask anything specifically?
um, no autoimmune any condition.
Now, in this case, since it occurred along with the accident,
Okay.
it's not a familial disease.
Okay, sir.
But please remember, trivial trauma of any nature can precipitate quadriplegia or paraplegia in people who are having basic craniovertebral anomalies, a birth defect.
Okay, sir.
So, activities of daily living, what you would not know.
Whether the patient requires a help for doing his daily activity, since he is having a weakness of all the limbs, and um, the patient, whether he can do things by himself, whether he's bedbound or he's able to walk with help, with assistance.
What is the
Mm,
scale used to measure the ADL?
um, it is based on uh,
Barthel's index.
Barthel's
Okay.
index.
Patient is
Okay.
bedridden and completely dependent on his spouse for all daily activities,
Okay,
including
sir.
feeding, and bladder is catheterized.
Okay,
So,
sir.
important past history in a case of quadriplegia. Other than road traffic accident, a case of paraplegia, quadriplegia comes to you, what all
Yes, sir.
things come to your mind and how do you proceed?
Um, as mentioned, the whether the patient is having any comorbidities, we can ask hypertension, then diabetes, then whether there is any dyslipidemia, coronary artery diseases, then
No. In this case, our problem is quadriplegia.
okay
So when
sir,
you ask important past history, we are aiming at localizing a diagnosis,
okay
etiological
sir,
diagnosis. So what all things you would like to ask?
cervical spondylosis,
That's correct. Correct.
uh, then
So you already ask history of trauma is there.
okay
Suppose there's
sir,
a history of fever. What
mm,
are the possibilities? Fever with the paraplegia.
um, uh, uh, it can be some meningeal irritation,
Fever
uh,
can be yes, meningoencephalitis.
diabetes. Then Guillain-Barré syndrome.
Rarely yes.
Then
When somebody comes with acute onset of fever, rigor chills, acute onset of paraplegia, what will you suspect? And some tenderness of the spine, what will you suspect? Any treatable option comes to your mind,
uh,
epidural abscess.
epidural
If you
abscess.
drain it, patient gets absolutely well. So
Okay, sir.
fever at the beginning should always, we must think whether I'm missing something which is very,
Okay,
very
sir.
treatable.
Okay.
Tuberculosis
Uh,
can
s-
produce,
spine, TB of the spine can produce.
can produce. Okay.
Uh,
Can you tell some mechanisms by which TB produces quadriplegia?
um, when it affects the um, pods, uh,
The bone may be fractured,
fracture of the bone, and
compressed.
it can compress as well. Yes, sir.
It can produce a cold abscess that can
Yes,
also
sir.
press upon.
Okay, sir.
There can be associated arachnoid infection, arachnoiditis, and
Okay.
tuberculosis is well known to produce arteritis. It can
Okay.
produce tuberculous arteritis and occlusion of the ischemia of the spine. What about
Okay.
HIV infection? What does HIV produces uh, paraplegia or quadriplegia?
Um, yeah, it can cause a, Kaposi sarcoma. No. Um,
HIV is well known to
compre-
produce
opportunistic infection causing meningitis, cryptococcal meningitis, uh, causing meningeal irritation, which can result in.
okay, so in a seroconversion stage, HIV can produce something like a Guillain-Barré syndrome.
Okay, sir.
It can also present as AIDP or rare it can present as CADP later on. As
Okay,
you
sir.
correctly pointed out, there are a lot of infections. Classical being TB,
Yes, sir.
CM infection. Okay,
Okay,
there can
sir.
be associated other STDs like syphilis, which can produce problem. There can be HTLV virus, HTLV1, which can create problems.
Okay,
And
sir.
later on, HIV can directly affect the spine, called as vacuolar myelopathy.
Okay, sir.
Okay,
Okay.
so there's something called as tropical spastic paraplegia produced by retrovirus HTLV, retrovirus producing paraplegia, quadriplegia, commonly seen in African countries or
Okay, sir.
Japanese islands and so on. And histo drop attacks. Now tell me something about drop attacks. What do you mean by drop attacks? Somebody dropped. What is drop
Uh,
attacks?
a sudden spontaneous fall while the patient is walking or standing, and
It's syncope.
it's a syncope. Okay.
It
And
is not syncope. It is not syncope.
with recovery occurring in minutes,
Syncope, you have a loss of consciousness.
the
Drop
patient will.
attacks,
Okay, sir.
patient is fully conscious, alert.
Okay, sir.
So what, give some examples of diseases producing this type of problems.
Meniere's disease, ear. Uh,
In relation to the
uh,
neurological diseases, we
yeah.
think colloid cysts of third ventricle can produce
Okay,
drop attacks. Last time I think we discussed about cataplexy.
cataplexy.
can
Yes.
produce drop attacks.
Okay.
What's called as cherry malformation, again you can have drop attacks. So this may be relevant not in this patient but some other patient. So based upon what is told to you, what's your provisional diagnosis here?
Um, the patient is having a traumatic quadriplegia following an RTA because there is
So
no evidence.
so you have given the physiological diagnosis,
Yes, sir.
quadriplegia, that's correct. Tell me
Okay.
anatomical diagnosis.
Uh, lesion above C5.
That's correct thinking, very good thinking. So she has got spinal cord problem, etiology is trauma. Okay,
Okay.
that is clear. Okay, so what are the common causes of quadriplegia?
Um, high cervical cord compression. Then it can be cerebral palsy. Is she any the motor neuron disease? Then Guillain-Barré syndrome. Then there can be craniovertebral anomalies. Then uh, cervical spondylosis. Then patient can have in case of multiple sclerosis. Then
So we may be discussing under different headings like acute quadriplegia, insidious subacute onset, chronic or lapsing variety.
okay,
So there may be different causes.
okay,
So
sir.
one important cause is vascular territory problem, anterior
Okay,
spinal artery thrombosis. What are the
okay.
expected findings?
Um, in case of anterior, uh, there will be uh, uh, um, weakness.
No.
Then
Tell me the blood supply spinal cord. Anterior spinal artery supplies which part of spinal cord?
um, uh, all that is except the dorsal column.
Good, 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 very good. So
Uh,
the finding will be dorsal
uh,
column sensation will be normal. All other
okay.
findings will be lost. So anterior two-third, all functions will lost. Dorsal column function will be retained.
Okay.
That's how we diagnose. There's something like a dissociated sensory loss.
Okay,
Brain
sir.
temperature will be lost. Posterior column sensations and touch may be preserved.
Preserved.
So you already mentioned about cervical spondylosis, fractures, IVDP, Guillain-Barré you mentioned, craniovertebral anomalies you already mentioned, AV
Yes, sir.
malformations can produce same problem, and then
Okay.
comes the periodic paralysis. Tell one sentence about periodic paralysis.
Um, it is the patient can recover following the
Excellent.
paralysis.
So it comes and goes. Comes and
Yes.
goes. Okay. And we have got spinal cord injury following trauma. So how does spinal cord injury produce paraplegia?
There can be the compression of the spinal cord by the fractured bones. Then any hematoma formation which can compress. Then avulsion of the spinal cord and whiplash injury.
So what
Uh,
is hematomelia?
um, collection of blood. Uh, no.
Where?
Um, in uh, in
Bleeding
the
into the spinal cord.
bleeding into the spinal cord. Okay.
So, so these are the mechanisms by which spinal cord is affected following trauma. Now, can you tell me the some mechanisms? So this mechanism, some
Mm-hmm.
presentations, some syndromes in relation to traumatic paraplegia. If it affects the anterior spinal artery, it will mimic a anterior spinal artery injury. It can
Okay.
mimic a Brown-Sequard syndrome if it is
Okay.
a symmetrical type of injury.
That's
So
right.
tell me
Okay.
something about Brown-Sequard syndrome.
Following the hemisection of the spinal cord, uh, there is uh, uh, um, at the um, dissociated sensory loss
Okay,
will be
you are
present
right. You are right.
in
That particular side will be paralyzed.
okay.
Motor wise, that particular side will be paralyzed, and sensory wise, at that same side, there will be a band of hyperesthesia, and opposite side there will be loss of
Temperature
sensory loss.
sensory loss.
So one side it will be the loss of
Uh, it's dorsal column
dorsal
sensation.
column, same side, and
Contralateral side, there will be a loss of
so
spinothalamic.
so it's a dissociation.
Okay,
So you said this is a dissociation.
okay, sir.
So it can produce dissociation, and
Okay.
sometimes it can produce posterior cord syndrome. So what happens in posterior cord syndrome?
Uh,
Just opposite of anterior spinal occlusion. Posterior dorsal column is affected, rest is
okay,
okay.
okay, sir.
And rarely you may get what is called as central cord lesion. So what is central cord lesion?
Uh, Central uh, cervical spinal cord is affected.
No,
Uh,
central cord means inside the center of the
uh,
spinal cord, around the
okay,
central canal, there is bleeding or injury, and this type of illness produces just like the findings in case of syringomyelia, the
okay,
crossing fibers will be affected. So these are the ways in which produces. Okay.
okay, sir.
On examination of this particular patient, these are the findings.
Uh, Sir, should I read it?
You
Or,
read important things only. Left side is all normal things except for a bed sore. Right
okay.
side, higher functions, okay. Cranials are normal. Motor
Uh,
system, motor system.
there is spasticity of all the four limbs. Power, neck strong. Upper limb and lower limb, grade 0. Beaver sign is negative. And reflexes, there is a bilateral extensor plantar response. Abdominal reflex is absent. Cremasteric reflex is absent. And the deep reflexes all are exaggerated.
So you said there is spasticity. Tell me
Yes.
about spasticity. What's the definition of spasticity?
Um, Spasticity, it is velocity dependent. Uh, it is indicating a pyramidal lesion, and uh, it is velocity dependent. Um,
It's a
uh,
situation
uh,
characterized by increased muscle tone.
okay.
Number one. Number two, due to hyperexcitability of
Okay.
the stretch reflexes.
Okay, sir.
And three, is velocity dependent,
Yes.
eh,
Okay.
in
Okay, sir.
producing in the increase in the tone in the stretch reflexes.
Reflexes. Okay.
So all the four limbs are spastic.
Everything is
What does
spastic.
it mean to you?
It can indicate a pyramidal lesion.
Pyramidal lesion. So all the four limbs are spastic, and
Okay.
you got zero power. So when you have a paraplegia or quadriplegia, you are trying to localize motor wise, sensory wise, and reflex wise. So
Okay.
motor wise, if a person is not able to abduct his shoulder, where where do you motor wise localize?
Uh, Abduct shoulder. Um, C C C5.
C5 lesion. Suppose you are not able to abduct your fingers. Fingers cannot be abducted. Where do you localize?
C8 uh,
You localize at level of T1.
T1. Okay, sir.
Suppose you are not able to dorsiflex your wrist. Where do you localize?
Flex wrist. Um,
C,
Sitting. C7.
C6, C6.
C6. Okay.
Suppose you are not able to flex your fingers. Where do you localize? C8.
C8.
And how do you localize C7?
C7. Uh,
So you do the
Extension of elbow.
extension elbow. Very good. The triceps power you are checking. So this is how you localize C5, C6, C7, C8, T1, the upper limb. Abdomen, how do you localize?
We do the beaver sign.
Beaver sign. Okay, that's good. Lower limb, hip flexion, root value.
Okay. Okay.
Hip flexion,
Hip flexion. Uh,
L2. Knee extension,
L2.
L3. Dorsiflexion of the ankle, L4. Dorsiflexion of the big toe, it is L5.
L5.
All the toes, L5. And plantar flexion is
S1.
S1. So you know, by muscle power you can localize where is the problem.
Okay, sir.
Okay, reflex wise, plantar is extensor. Where do you localize the lesion?
Extensor plantar. S1. You upgoing plantar, so it's an upper motor neuron lesion.
So extensor,
S1. Sorry, sir. S1.
extensor plantar indicates it's a pyramidal lesion.
Okay, sir.
So pyramidal lesion above the level of L5.
L5. Okay.
Above the level of L5, from cortex downwards anywhere.
Okay, sir.
So here it is a bilateral pyramidal lesion.
Bilateral.
Okay, abdominal reflex are absent. So what do you think about that?
There is a um, uh, um, um,
In pyramidal lesion, abdominal reflex will be absent.
okay, sir.
Cremastic will also be absent.
Absent.
So in here, all the deep tendon jerks are exaggerated. How do you localize reflex wise?
Knee, each reflex, that is,
No, all the reflexes are exaggerated. So name the reflexes.
um, the knee jerk, angle jerk, then biceps, biceps jerk, triceps, then supinator jerk.
So above C5,
Okay,
above biceps, no?
yes, sir.
That's right. General physical examination findings in quadriplegia, what all things you specifically look for? In this case, clear, it's a trauma. Otherwise, what all things you look for?
We have to look for in case of whether it's a craniofacial, it's if there is any anomaly, so craniofacial abnormality can be looked for. Then whether if it's a any neurofibromatosis is present, then
So you look for certain things. Hypotension is very characteristic for AIDP.
okay, sir.
You have to look for birth defects. That's why you're looking for proportion between your length of your neck and your height.
Okay, sir.
Neurofibroma is looked for. In a case of trauma, if the vertebra is fractured, you may get a gibbous. TB, you can get a gibbous.
Okay, sir.
Tumors, you can get a gibbous. So gibbous may be a clue site of localization.
Okay.
So certain things you look for in the general physical examination of all patient quadriplegia. So just for completion's sake, name few craniovertebral junction anomalies. So these are all
okay.
as undergrad students, it's enough if you just know the names. You need not know more details about it.
Okay.
So in a case of quadriplegia, you're asking me specifically about cranial nerve abnormalities. What are you looking for?
We are looking for cranial nerve
So,
to
in a case of multiple sclerosis, you
okay
may
sir.
get optic atrophy.
Okay sir.
Optic neuritis, you may get papilledema-like picture.
Mm,
If there's a tumor inside the
mm,
brain, papilledema.
okay sir.
3, 4, 6 may show
Down
nystagmus.
with
Downward nystagmus indicates that high cervical cord lesion.
okay sir.
So what is nystagmus?
Um, they are the pupils are moving. They are rhythmic rotatory movements of the uh, pupil.
Okay, so there's a mistake there. Spelling mistake is a nystagmus, and there's a spelling mistake in the answer also. It is nothing to do with the pupil. Nystagmus is a involuntary,
Okay sir.
jerky, rhythmical movements of the eyeballs when
Eyeballs.
eyes are fixed on an object.
Okay sir.
Okay,
Okay.
and fifth nerve, we will come to that later on. Seventh nerve, we are looking for facial palsy.
Um, because uh, it is a in case of Guillain-Barré syndrome,
You can have
fa-
facial palsy is
okay.
possible. And lower down cranials can be affected when there is a high cervical cord lesion.
Okay.
Yeah. Now you said above C5 is in a exaggerated bicep jerk.
Biceps.
How do you know it's above C4?
Uh,
We put your finger on the pectoralis major laterally and tap on that with the knee hammer, and you can see the exaggerated contraction of pectoralis major. This is called
okay, so
as
pectoral reflex.
pectoral reflex.
Okay.
So this patient bladder was affected. So what are symptoms of human bladder?
Uh, there will be bladder incontinence,
Hmm.
then um, um,
No,
a loss of
when the skeletal muscles are affected by human disease, it produces spasticity.
okay, so
Bladder also becomes spastic. So
okay,
spastic bladder will be small. It will contain very little urine. The
okay, so
patient evacuates bladder more frequently and each time small quantities of urine.
okay,
A lemon bladder will be hypotonic.
okay,
It
so
contains large amounts of urine and never comes out. It just dribbles out. That's all.
okay, so
So history of bladder is important for us.
okay, so
And what symptom people have if there's a human bladder?
uh,
One more symptom.
frequent
One more symptom. They have precipitancy. What do you mean by precipitancy?
uh, precipitancy f- initiation becomes difficult.
No.
uh,
Precipitancy means patient has got desire to pass urine. Sensation is there. Patient moves to the urinal. Even before reaching there, urine comes out. That means
okay,
they don't have capacity to hold urine. That's called precipitancy. That's sign of human bladder. Okay.
okay, so
So increased frequency, low volume, maybe with the precipitancy. Okay. Now comes Vishnu Priya. Where is Vishnu Priya? Okay, Vishnu Priya.
Yes, sir.
Tell me some causes for spastic paraplegia or spastic quadriplegia. They present a case of traumatic paraplegia. That's good enough for them. But what about other causes?
Sir, syringomyelia affecting
Syringomyelia is a good answer. Yes. Agreed.
infectious causes.
What is the commonest cause in our community? Cervical spondylosis.
Okay.
Cervical spondylosis is very common community.
Okay,
Tumors are not rare. And
Yes,
you do get case of multiple sclerosis. Okay, antispinal artery and trauma was already mentioned. Now and then we get patients with B12 deficiency, subacute combined degeneration. Okay. And by birth, people get conditions like syringomyelia and any other hereditary spastic paraplegia, Friedreich's ataxia. Okay. Can an intracranial disease produce spastic paraparesis?
Yes, sir. Sir, butterfly. Sir,
Where is butterfly?
venous sinus thrombosis.
That's one cause.
Parasagittal sinus.
Parasagittal meningioma can produce. So leg areas can be affected. Any other cause? If it's acute onset, what will you suspect? Intracranial problem, acute onset within few minutes. Sometimes the anterior, which blood vessel supplies the leg area? Posterior cerebral or middle cerebral?
Middle cerebral.
It is the anterior cerebral that supplies the leg area. So if there's one single blood vessel supplying both sides, that can produce problem. And many of these patients come with a shock stage. When they come with the paraplegia, traumatic paraplegia, they come with a shock. So what is the possible cause for shock? How do you define shock? Definition shock.
Patient is in hypotension.
Now what should be the cutoff value for you?
BP less than, systolic BP less than 90, and
Usually the shock is defined as mean arterial pressure less than 65. So how do you calculate mean arterial pressure? Yes, how do you calculate mean arterial pressure?
it is systolic BP plus 2 times diastolic BP whole divided by 3.
Diastolic BP plus 1/3 of pulse pressure. Okay, so what are the mechanisms by which people become shock stage in traumatic paraplegia?
Neurogenic shock is a cause.
Or it can be hypovolemic shock.
Okay.
When you fall down from a tree or accident, there may be some volume loss also. That can also produce shock. So it's your job to differentiate between the two. How do you differentiate? In both conditions, BP is low. In neurogenic shock, you expect bradycardia. In hypovolemic shock, you expect tachycardia. In hypovolemic shock, you expect extremities to be cold. In neurogenic, you expect it to be normal. And if you measure the urine output next few hours, neurogenic, what is the urine output?
It can be normal.
Normal. And in hypovolemia, it is oliguria. So what's the mechanism of shock in both conditions?
Hypoperfusion in hypovolemic shock and pre-renal.
Hypovolemia circulatory volume is less. So you have got loss of blood volume and decreased perfusion. Okay. And neurogenic? So tell me the structure of spinal cord. Where is the sympathetic fiber situated?
It is in the lateral horn autonomic.
Yes, there is a sympathetic outflow specifically meant for this, and that is site of. Okay, before you proceed further, this patient was found to have a bed sore. How do you grade bed sores? How many grades are there?
There are 4 grades.
4 grade means, tell me about each grade.
Grade 1, there will be only erythema or color change of the skin.
That's right.
Grade 2 is on the loss of epidermis
and blister formation. And grade 3
involvement of deeper dermis
and fat also. And 4 is
loss of muscle underlying bone.
bone muscle tendons can be seen. So to answer a few more questions, what is balaclava? There's a mention about balaclava along with fifth nerve. What is balaclava?
Sorry, sir.
So balaclava is a particular type of mask which covers your face and your neck except part of the face. Maybe the eye is exposed, nose is exposed, rest of the areas are covered. It's a special type of balaclava. So why you are talking about balaclava in the case of quadriplegia?
Sir, it is involvement of fifth nerve, trigeminal nerve, maybe loss of sensation or the face.
And a fifth nerve has got a definite area of sensory loss. Three divisions are there. Three division produces sensory loss, three different areas. But here is a situation where these areas are specifically spared. This is a classical sensory distribution for syringomyelia becoming syringobulbia. Because it is affecting the trigeminal nucleus. Okay, so you get something like onion peel appearance. That's why you get this what's called as balaclava type of. Okay, tell me something about difference between UMN and LMN. Cause of LMN paraplegia.
LMN paraplegia we get at the level of lesion.
But lower down it will be UMN, no?
Yes, sir.
LMN paraplegia is commonly seen when you got myopathy. She has already mentioned. When you got neuropathy, when you have plexopathies, okay, peripheral neuropathies, you have got anterior horn cell disease, then you have got Guillain-Barré-like things, root involvement. Or they are all classical examples of LMN type of paraplegia. Okay, to summarize, tell me something about geographical paraplegias. Certain areas in India have got paraplegias. Many people are paralyzed. Can you tell some examples of that?
Yes, sir.
What is fluorosis? When your water is not good, drinking water is not good, it can be a lot of fluoride. You get deposit in your bones and it overgrows and press up on the nerves, they come into paraplegia. So where are all this fluorosis seen in India? Except Kerala, almost everywhere it is there. First described from Andhra Pradesh, plenty of cases in Batinda district of Punjab. So many pockets are there in India. And tell me something about ladarism.
Sir, it is a poison.
It's a poison, yes.
Ladara sativus. It is a contaminant in the food.
Which food? Which food? Cheese or mutton?
Grains.
Which grain? Kasiri dal.
Yes, sir.
Is a contamination of kasiri dal producing paraplegia. So to summarize, today's case is a case of quadriplegia following trauma, and we are discussing how to localize it. So going back to Vishnupriya, they have already said about localization according to motor power. They already said about localization according to the reflex level. Now it is your job to say about the localization sensory level. Tell me how to localize. Just according to dermatome. So tell me dermatomes.
C1 supplies the occipital area.
C1 has no sensory supply. The occipital is supplied by C2. Neck is supplied by C3. Above the clavicle is supplied by C4. Deltoid is C5. Your thumb and index finger supplied by C6. C7 supplied by, middle finger is supplied by
C7.
How do you remember that? If you look at the spine, you have 7 cervical vertebra and 7th is the biggest one, longest one, and the spine of the 7th projects out. So same way your finger also, middle one projects out. Is the easy way to remember. Next two are C8. Axilla is supplied by what?
T1.
T3. Where is T1?
T1 is the
medial
medial
side of your forearm.
arm.
Higher up it's the arm. Then comes axilla. And then where is T4?
T4 at the level of nipples.
Okay, T6.
T6 cyphoid process.
T10.
T10 at the level of umbilicus.
Soles.
Soles.
S1. So you have to read basically about the flexus root value, muscle power root value, and dermatomes. Accordingly, you can localize. So when there's a case of spinal cord disease, you tell physiologically what's the problem. This is a quadriplegia. Number 2 varies level above the level of C4. Okay. Then you are going to tell what's the etiology. Here's the trauma. It may be complete transection or maybe contusion or laceration, whatever it be. Post-traumatic paraplegia, we are localized at level and it's a UMN type of bladder producing infection. And whenever there's infection, your tendency to go for flexor spasms. It's time for students to ask questions.